Good evening, everyone. My name is Annie Benzi. I'm chair of the SSAT Complex GI Surgery Fellow Subcommittee, and we have a great talk tonight for our Grand Round series. I would like to introduce Dr. Shaheen Ayazi, who is a foregut surgeon in Pittsburgh at the Esophageal Institute, as well as a member of SSAT, as our moderator tonight. And Dr. Ayazi, if you wouldn't mind introducing our fellows and just giving us an overview of this topic.
Sure. Thank you for inviting me. This is actually a very interesting talk. To give you a little bit of historic background, for the past 50 years, we've been diagnosing reflux disease based on characterizing intraluminal pH. Dr. Tom Demister invented ambulatory pH monitoring in 1975, and in fact, we are celebrating 50-year anniversary of this technology this year. We are having a session at SSAT in San Diego this year, celebrating this event and also having talks about the role of different physiology testing in predicting pH monitoring, in predicting a surgical outcome of any foregut procedure. The newest technology in the field is mucosal impedance. Unlike pH that characterizes intraluminal pH, mucosal impedance measures the conductivity of the based on the distance of the intracellular space. We're going to talk in much more details, and fellows from Portland Clinic have prepared a wonderful talk. They're starting from different physiologic modality, and they end with the mucosal impedance. I would like to introduce them, Dr. Hegdi, Dr. Karimzad, and Dr. Rafiki are the fellows from Portland that they're gonna go through all these modality for us today.
All right. Hi, thank you, Dr. Yazi, and everyone for having us here. Yeah, like Dr. Yazi said, my name is Talha Rafiki. Mohammed Karimzad and Shruti Hegde are my co-fellows from Providence, Portland, and the Oregon Clinic. We're going to be discussing mucosal impedance testing and its utility in diagnosis and management of a variety of esophageal disease. So before we jump to that, just a quick overview of the diagnostic approach to GERD. This is generally the workup used for many esophageal disorders. The differential can be quite broad for esophageal complaints, so a whole litany of tests is used to narrow this down. When GERD is strongly suggested based on history, an empiric PPI trial may be employed, but generally more is required. And a lot of this stuff, a lot of these guidelines kind of are developed in conjunction with gastroenterologists. And as surgeons, our approach can be a little bit different at times. So as we go through this, we'll kind of emphasize some of those differences. So endoscopy is, of course, a thorough physical exam. That's really our physical exam of the esophagus and the stomach. And then there's pH testing, which is now combined with impedance testing, which we'll talk about, can provide objective evidence of fluid reflux. Then there's manometry to evaluate for motility disorders, while esophagram delineates the anatomy for surgical planning. There are some other adjuncts that may be used, such as impedance planimetry, also known as the endoflip, and gastric emptying studies. Out of this algorithm, for this talk, we're going to focus mainly on impedance, which takes many forms. pH impedance testing, which is what we most commonly see, is quite distinct from mucosal impedance testing. So keep this in mind as we move through the presentation. So what exactly is impedance? Simply put, it's a measurement of resistance or opposition to the flow of electric current through a medium. The medium can be air, fluid, or tissue. Generally, the more ions that are present, the lower the impedance due to increased conductivity. Air has fewer ions than liquid and is less conductive, so impedance is higher in air than in water. Impedance in tissues is affected by different things, or a variety of factors, including water and fat content, intracellular gaps, etc. This is a very important concept when discussing the different applications of impedance testing as we move forward. This picture basically shows how a fluid bolus, which contains many ions and thus is more conductive, has lower impedance compared to no bolus, in which impedance is raised by the absence of ions. Now let's revisit our GERD diagnostic algorithm, which is pictured here. Notice how impedance shows up twice here. These are two distinct applications of impedance testing. My colleagues will go into this in more detail, but with modern technology, we can measure both the pH of refluxate as well as impedance early in the diagnostic algorithm. This is one of our four big foregut tests that we do. This way, if there is any refluxate that is not acid in nature, it can be still be detected through impedance testing during the pH impedance test. Lower down in the algorithm here, when pH testing is inconclusive and that acid exposure time is less than 6%, distal mean nocturnal baseline impedance can be measured to differentiate between functional heartburn and esophageal hypersensitivity. This is a newer parameter added to the 24-hour impedance pH monitoring, and this basically measures the distal esophageal tissue impedance. The 2.292 kiloohms is around the normal resistance of tissue in the region. And the technology we're going to talk about later is going to build on the concept with this test. So a higher distal mean nocturnal baseline impedance indicates functional heartburn, where there may be no mucosal damage associated with symptoms, while a lower value may indicate esophageal hypersensitivity, in which very mild reflux, not enough to cause damage, manifests in symptoms. Importantly, the Lyon 2 consensus suggests that these values, less than 1500, present adjunctive evidence of GERD, but is not diagnostic of it. Low mucosal impedance in this test may indicate ongoing reflux, but it cannot differentiate between stasis and mucosal injury. And that's something my colleagues will touch on a little bit later. So for the purposes of this talk, we'll focus on the overall differences between impedance testing of refluxate and of mucosa, and discuss how neuromucosal impedance testing modalities can help with diagnosis and with monitoring of various diseases. Some of this algorithm has been updated in the Lyon 2 consensus, but these updates won't be too relevant to our discussion. Also keep in mind that, as I mentioned earlier, a lot of this algorithm was developed by our GI colleagues. And as surgeons, our approach is basically to figure out how we're going to reconstruct the anatomy to solve the patient's problems. So, and to avoid complications. So our approach may be a little bit different. So from here, my colleague Mohammed will continue with the discussion of pH impedance testing, which is one of the established necessary steps.
Great, thank you, Tala. Really quickly, we're just going to go over the pH impedance procedure and what the patients would typically be undergoing when this occurs. So the patients would have a regular would come in the day of their procedure, manometrically using a high resolution manometry, which is typically done for the full foregut workup. You would identify the lower esophageal sphincter, and then these probes are then placed, small catheter probes are placed transnasally, where the most distal probe is 5 centimeters above the lower esophageal sphincter. So unfortunately, there's could be patient noncompliance due to intolerability of this probe. Some of the setbacks with these kind of technology is that you should be looking at the data yourself. There is software that automatically will give you a readout of the qualities of the readout that you have over the 24-hour monitoring period, which one should be looking at themselves. But nonetheless, that's a pretty time-consuming thing to do. Now, when these pH impedance catheters are placed for 24 hours, they continuously record. Patients are given a record to record any log to record any symptoms they have. Additionally, the actual recorder they have has the ability to notate symptoms that they have, and they're also asked to record any kind of changes in their being recumbent position or supine when they sleep. If we can go to the next slide. So we're going to really go through from left to right what impedance would look like when we look at the graphs, and it's going to become a little more apparent as we go on to these next slides. As Taha discussed, we're looking at the refluxate. We're looking at what things are going through the esophagus with this catheter that's been placed in the esophagus. So in the beginning, we draw a baseline. If we look at the left side of the graph here, we get the baseline impedance, which is really either gas that's stably around the catheter and partially some contribution of the mucosa. But again, this is very different from the direct mucosal impedance that we'll discuss later. So we start off with baseline. If there's air passing through, such as can be a belch, impedance rises. If a liquid bolus passes through, the impedance drops. Why? Because there's more ions within there, thus creating a decrease in the impedance or resistance. And when there are contractions, you may have some reverberations and variability, however, eventually come back to, after some undulation, as you see on the right side, to a baseline. Now, this can be further characterized, well, it's liquid. What does that liquid have? Does it have acid? Does it have some acid? Does it have no acid? We're going to get into that. Let's go ahead to the next slide, please. This is what the catheter looks like. The esophagus is pictured on the left. Here we have multiple sensors, an array of sensors or channels that have been placed throughout the esophagus. Typically, you'll have 4 sensors distally and 2 proximally, named Z1 through Z6. And in particular, there is a pH sensor that's also incorporated in this, hence pH impedance. That is always situated 5 centimeters above the lower esophageal sphincter. Remember, it's very important that we measure this out manometrically initially. The readout that we get is on the right side. Each of those sensors starts out again with the baseline, and as they go through the 24-hour period of recording, there are changes in the impedance that then we interpret. This can be interpreted manually, but again, now we have software that helps us do this, and we only look at a qualitative view of the readouts. Now, one thing that is important, Tala mentioned the MNBI. That is a measure that is taken overnight at 10-minute intervals, typically in the early morning hours between 1 to 4 a.m. or so, stable timeframes of baseline mucosal impedance that is measured. Next slide, please. So how do we interpret this? In its most essential form, we want to identify liquid bolus reflux. We want to know things that are coming up from the stomach into the esophagus and causing symptoms. If we look on the left side, the x-axis is time. The y-axis, again, are the multiple impedance graphs that we have. We started off at a baseline. Squiggles a little bit, but it's pretty stable. Then we have a drop. Now you see that drop is greater than half of the greater than 50% of the baseline impedance. These, throughout all those channels, will count as a liquid bolus. Now, over time, the spatial temporal arrangement is very important. Over time, as we see, when we start from the bottom, the most distal channel, we notice where there is that dip in the there's a dip in the impedance. Now, to be more technical about it, the bolus entry is at the 50%. We're not going to get too technical about it. The biggest thing here to notice is that there is a significant drop in impedance. As you go up, you notice that that drop occurred earlier. And because of that, what's happening here is because we have a drop of the impedance on top and on top of the esophagus, and as we go lower, we see it later. That means that the liquid bolus is going from top to bottom. What's that? It's a swallow. Now, reflux, on the other hand, is the opposite. If we look at it again from the bottom, we notice the bolus entry where the impedance drops on the lowest sensor. And as we go up, we notice that we've already had that drop in impedance. So this is hence a reflux event or a liquid bolus reflux event. All right, next slide. So now we're going to look at these different types of events, and we're going to typify them as if they're acidic or not. So, but in order to do that, we have to look at 2 different kinds and characters of readouts. One is the impedance, the other one is the pH. And we're going to put them together. So first, we're going to start off. When we look at the impedance, there's a drop in impedance greater than 50%. That means that there's some kind of liquid bolus there. So those two black boxes there. I'm only showing those two because the technical definition is you need at least two distal leads that dictate this. But if we look at that, we have our significant drop. You'll notice a little uptick right before. That's a little bit of gas, but they have the drop. Now, again, just like before, we're going to see, okay, well, we look at the bolus entry. We entered much earlier on the distal leads than we did in the proximal leads. That's going to be a retrograde flow or a reflux event. Now, is this reflux event have significant acid exposure or not? Next slide. The line that you see drawn there is the line at pH of 4. That is our threshold for a acidic event. We see that temporally there is an association of a drop in pH in that catheter at 5 centimeters that coincides with this retrograde event. Hence, this is an acid reflux event. So next slide. Now, in a very similar manner, a weakly acidic reflux just means that you are between a pH of 4 and 7. You've dropped below 7, but you're between 4 and 7. So again, we have a retrograde flow in our impedance catheters. We have the pH readout, and we put these together, and hence we know it's weakly acidic. Next slide, please. We can actually advance twice. Great. Next is our alkaline reflux. Again, we have our impedance drop greater than 50%. Again, the definitions don't change. In the distal leads, we find there's a greater than 50% drop. Once again, this is a retrograde flow. It's going from distal to proximal. And the pH actually is stuck around 7. This is alkaline reflux. Next slide, please. So here we're going to compare acid reflux versus non-acid reflux again to kind of recap. We're going to look at what a true printout would look like. You know, you're seeing it over time. This is about a minute and a half of a readout. On the left side, again, we see that all these leads have a retrograde flow. We drop below that dotted line on the pH probe at 4. It's temporally related, therefore acidic reflux. On the right side, we had a drop in pH between 4 and 7. However, it did not reach the significant of 4, pH of 4, so it's called a non-acid reflux. Recall earlier I said weak acid. There was a push to, and not a push, but even the actual interpretation when you're looking at impedance is to typify it into acid reflux or non-acid reflux. Those non-acid refluxes are typically actually weakly acidic refluxes. So pretty much more or less one and the same. Next slide, please. We're going to go through what at our institution, our readouts look like. Again, this is over a period of 24 hours. We have our pH at the bottom. We have our catheters running from 1 to 6. And, you know, we have different colors to kind of help with the aid in visualization. But this also comes with a nice readout. If we look at the next one, which is here. So looking at, first and foremost, our reflux episodes. On the right-hand side here, I've written out, I've included pictures from Lyon's 2 criteria, which is our criteria for GERD. But I want us to go through a sample report. Next slide. Here, no, that's a little too much. Thank you. If we look here where we're highlighted, this is the readout. You'll see, again, acid, non-acid, all reflux events. And then we have proximal extent as in, you know, how high up on which channel you have the reflex come up to. Not so important, but I want us to focus mainly on the all reflex metrics. So typically a greater than 80 reflux episodes, as you can see by the Lyon's 2.0 criteria, is conclusive evidence for pathologic reflux. So looking at that, those numbers between the conventional Lyon won't change, the 61, 61. It's just that there are some differences in what Lyon says versus what's measured. It doesn't matter. This person had 61 reflux events. This was not conclusive evidence for reflux per se. Next slide, please. Now, there's also a association of symptoms, or the symptom index. Symptom index is, again, the patient is able to indicate when they have a heartburn or a regurgitation event of sort, or a cough, and these will then be correlated with these events. Typically, if it's greater than 50%, this would indicate that there is correlation. In this case, this person did have correlation with the reflux events that they had, but again, they did not have greater than 80, which is confirmatory evidence. Next slide. And last but not least, we're looking at the pure acidic component of the pH impedance study. We get a great couple of information here. The two biggest numbers to look at here, one is the Demeester composite score, as you see in the blue, and the lower blue box, typically above 14.7 is indicative of reflux. Now, this isn't harped on too much in Leon's and 2.0, but as surgeons, we do use a Demeester score much more robustly, as potentially our GI colleagues do. And it also includes some granularity of the evidence, as in time in reflux, in the upright or in the recumbent position, in the longest episode. That hence why it's a composite number. But at its purest form, the total time in reflux, which was shown here, I indicated in blue. Nonetheless, the total time in reflux, which is the AET, or the acid exposure time, that the Leon's criteria clearly indicates greater than, that would be indicative of reflux, is what across the board GI and surgeons look at. And again, here is 3.8, did not gain any significance there. Next slide, please. So with any comprehensive initial foregut evaluation, an upper GI and EGD, high-res illuminometry, and pH impedance are important. And we're going to go through some quick little cases to apply the pH impedance. In this first case, a 50-year-old man who's fairly healthy, who's complains of heartburn and a sore throat. His symptoms are responsive to a PPI. We're looking at the upper GI here. We see that we clearly see rugal folds above the level of the diaphragm, and the two arrows that are coming in are actually the beginning of the esophageal ampulla. But nonetheless, the G junction is between those two, just above the rugal folds here, and this is a type 1 hernia. Next slide. On EGD, on a retroflex view, we find the diaphragmatic crus there, and well above both of those, and with the fundus in line with the G junction, we find that there is a herniation, a type 1 herniation in particular, of this patient. Biopsies indicate carditis or some inflammation at the G junction without any kind of metaplasia, and this patient had no H. pylori and otherwise normal gastric mucosa. Next. We always look at a manometry, of course, before we make any of our surgical decisions very quickly. We see that this patient had a swallow event, and the upper esophageal sphincter on top there had a swallow event. We have propagation of the peristalsis. There's no breaks in it. The IRP, or the relaxation of the lower esophageal sphincter, is complete. And what we call a DCI, or of course, as we all know, the strength of that contraction was within normal limits. Now we get on to the pH impedance here. Now, this is a single shot. Again, we've discussed this quite a bit now, but I wanted to again reemphasize retrograde flow, as we can see, where we have the arrow indicating how the drop in impedance distally occurs before it does proximally. And we have a concomitant drop in esophageal pH indicated in that lower lead there. Now, this patient had 124 reflux episodes, well above the 80, had an acid exposure time of 7%, had a Demeester of 36, and had high symptom correlation. So this makes a definitive diagnosis of GERD. Next. And underwent a hiatal hernia repair that we saw in an ISIT. Next, please. In case 2 is a 45-year-old woman. She has dysphagia and heartburn, history of hyperthyroidism, severe asthma, and atopic dermatitis. Next. Her upper GI is fairly unremarkable. And on EGD, we find her to have a feline esophagus, or the stacked coin-like appearance of her esophagus. They acquired the endoscopists had acquired 2 biopsies, one at the GE junction and one at 30 centimeters, which indicated no eosinophils and was otherwise unremarkable. Now, anytime we see feline esophagus, or we have someone who has quite a bit of allergies and they have coming out with dysphagia, a young woman in this case, this kind of is a little bit of a question stem to indicate, well, could they potentially have eosinophilic esophagitis? And in that case, I just want to put out the PSA that the recommendation is take at least 5 or 6 biopsies, and you want to span multiple biopsies at the distal, middle, and proximal esophagus, because a histological diagnosis is absolute key, especially seeing greater than 15 eosinophils. Next. On manometry, this person very quickly had 6 swallows of the 10 that we typically do in a manometry that had a DCI, or contractile effort, that was less than 450. That means they had an effective esophageal motility. Hence, she has got a weak esophagus. Next. On our impedance, we find that there's quite a bit of just these very flat lines, besides a couple swallows that she has. Does not have, is very much lower than what you would expect to see in each lead, at least the baseline impedance, compared to a normal patient or compared to a GERD patient. And in particular, you see that the 2,500 ohms is indicated on that first esophageal body probe. Each of these is well below that 2,500 mark. Next. Now, this is really important because here in A, we find that an impedance, typically across the length of the body, the length of the esophagus, the baseline impedance, mucosal impedance, will be much lower than those who have GERD or normals. On the left side, well below 2,500. On the right side, we see a patient without any kind of EOE, and we see a natural and gradual rise in that impedance as you go proximal from the squamous junction. However, again, in the EOE patient, this is a much lower baseline. And the mark that's typically made is some say, you could say 2,500. There's a good amount of specificity to say that the patient has EOE, but especially a 2,300 mark for well below the 2,300 ohms baseline impedance across the board, then there's about a greater than 90% sensitivity and specificity that a patient has EOE. Next. Or is at least supportive evidence. So nonetheless, this patient underwent a trial of budesonide, had some response, and eventually had to transition to a biologic and had significant response. Next. And in our last case, we have an interesting case of an older gentleman who had bad peptic ulcer disease and many, many years ago underwent a vagotomy and antrectomy with a Bill-Rod 2 reconstruction. He was complaining of regurgitation that's worsened only significantly over the past few years, and has a handful of times regurgitated bilious content. Again, for all of us to think about that anatomy again, Bill-Rod 2 reconstruction, we have the stomach that you have a jejunal limb that's brought up and therefore anastomosed. So it's post ampullary, and thus will have bile running through it at all times. Next. So again, upper GI with small bowel follow through, we found that we want to make sure that there's any kind of stricture or something. The gastrojejunal anastomosis is beautifully patent with brisk flow. And esophagus also is unremarkable. Next. There is significant bile, though, in the stomach on EGD and significant gastritis. Next. Now, the pH impedance study was really unremarkable for any kind of significant acid exposure. Didn't have significant reflux episodes. So no pathologic GERD. So because of his symptoms, he had to undergo what's called a Bilitech, which is a spectrophotometric monitor of bilious reflux, which is not used very often, but nonetheless was found to have increased bilious reflux episodes. Next. Um, it, because of this, he was converted to Roux-en-Y and has significant symptomatic improvement. Next. Now,
Before we move on to the mucosal impedance, we should
yes,
highlight two limitations of pH impedance. One
yes,
is, as highlighted by Dr. Dance in our message board, it has very limited utility in the postoperative setting. We get artificially high numbers primarily from intraesophageal reflux. The other limitation of pH impedance, although we all use it widely in the pre-op setting, is its limited ability to predict surgical outcome. With abnormal Demister score in distal esophageal pH monitoring, we have a very good tool to predict surgical outcome. We know patients with typical reflux symptoms who present to us and have an abnormal pH score, they are 4 times as likely to have a favorable outcome after anti-reflux surgery. This is not true with pH impedance component. None of the components of the pH impedance have been able to predict a favorable outcome to medical or surgical treatment.
thank you for that.
Thank you.
Really quickly, Tal, before we go, I don't know why that slide wasn't here. It's kind of going away, but one thing I did want to highlight in that last case presentation, which is big to know, is we talked about alkaline reflux earlier, and alkaline reflux is not directly correlative with bile reflux. That's significant to know because you could have the studies have been done on this. You can actually have a reflux episode that is alkaline in a patient who may be having significant bile reflux, and they may not even have much bile in that particular reflux episode, but there could be a weak acid or a full on acidic reflux event that does have bilious reflux involved. So a point I want to emphasize here is that impedance pH cannot be reliably necessarily used to detect bilious reflux, and there's other things like the Bilitech which could be used. Nonetheless, we typically will, in general practice, generally will use their in this case he had a frank known anatomy that puts him at high risk for it, as well as finding bile retention on EGD and whatnot. So it's a very clinical diagnosis. Okay, thanks a lot.
All right, no problems. All right, so now that we kind of have an understanding of pH impedance testing, along with the limitations, thank you, Dr. Ayazi. pH impedance testing tests for resistance to electrical flow and refluxate. So let's talk about direct mucosal impedance testing. There's a variety of different devices for this. Some remain in catheter form that are placed in direct contact with the mucosa using balloons, while others are devices attached to an endoscope, and these ones measure impedance in real time to provide a quick assessment of mucosal integrity. And most, if not all, these devices are designed to evaluate a majority of the esophageal mucosa. So in this picture, you see one of the catheter-based mucosal impedance devices. And when we compare it to a multi-channel impedance pH catheter, we see that on the right side, which is the impedance pH catheter, other than the addition of the pH probe at the bottom, there are more impedance sensors that are concentrated more distally in the esophagus, whereas in the catheter on the left, the sensors are placed pretty much throughout. The disadvantage of catheter-based testing, as mentioned earlier, is often patient compliance and tolerability. There's also a bit of a black box effect in patients with difficult to diagnose disease, in that patients with sporadic reflux may not show reflux during this testing period, which can delay or obscure the diagnosis sometimes. So let's talk about a different type of mucosal impedance testing device. One that we are gaining some experience with here is the Diversitech MyView, which works much differently and allows for a real-time assessment of mucosal impedance. So we'll start with this video, which kind of introduces how the device operates.
In response to the limitations of currently available ambulatory reflux tests, Diversitech Healthcare has developed an endoscopically placed probe to measure conductivity of the esophageal epithelium directly in a matter of seconds. Mucosal integrity, MI, is affected by the presence of dilated intercellular spaces, DIS, or spongiosis, which affects paracellular permeability of the esophageal lumen and is an important histologic feature in GERD and EOE. MI correlates inversely with spongiosis, differentiates esophageal disorders, rules out GERD, and monitors treatment response in GERD. My view from Diversitech Healthcare detects esophageal mucosal changes due to chronic GERD or EOE instantly during routine endoscopy. MyView EndoCap securely attaches to the endoscope, allowing for direct measurement visualization with built-in real-time measurement quality feedback that reduces overall procedure acquisition time. MyView potentially obviates the need for 24 to 48-hour ambulatory wireless pH monitoring or esophageal biopsies for histopathology. MyView instantly rules out a GERD diagnosis. This can help reduce diagnostic and treatment latency and might allow for monitoring disease activity over time. MyView Esophageal EndoCap, only from Diversitech Healthcare.
All right. So let's talk more about this device. Okay. So how does it work? They kind of mentioned it in the video, but it operates on the principle that other than refluxate or inflammation causing symptoms, there are residual effects of mucosal damage which affect tissue physiology. So Diversitech names this spongiosis because inflammation and mucosal damage cause larger intercellular spaces and increased mucosal permeability in conjunction with inflammatory fluid can result in decreased impedance. Um, so in a close-up of the image from the last slide, you see that as you move more distally, the impedance changes based on the disease. So distally, impedance is generally lower, even in normal tests, given physiologic reflux, but it is not so low as to indicate mucosal damage. However, in GERD, impedance starts off much lower distally, then increases toward normal proximally. In EOE, however, as the entire esophagus is affected, impedance changes minimally and remains low. Whoops, skipped a little bit. So this is how the technology displays their readings. The software measures the impedance values, and it's based off of like a cutoff, similar to that distal nocturnal mean baseline impedance of like 2300 or so. But either way, the software, as you run the device over the mucosa, the software gives you blue, yellow, or red, or sometimes orange in between as well. The red means low impedance. Yellow is kind of in between, and blue is pretty much normal or non-GERD. So we'll kind of go through that a little bit more, but I want to show you guys this live demonstration of this device. And you can kind of see how the readings are obtained. So usually you start off distally as distal in the esophagus. And then you withdraw the device, trying to keep it in contact with the mucosa throughout your endoscopy. And in this patient, you can see that distally, the zone is red, and it starts getting a little bit yellow. It starts getting more toward normal, and then as you go higher, it goes to blue. So based on the principles of how this technology works, this patient would have some sort of reflux, most likely GERD, because distally the impedance is very low, and higher up where the reflux doesn't reach as much, it's more normal. So let's go back to these readings, and we'll match them with the cases that Dr. Karimzada presented. First off, the blue is non-GERD or normal. EOE, which was case number 2, is going to be red throughout. because of global inflammation and mucosal damage. GERD will show the gradient pattern here on the right, which we saw in case number 1. And bile reflux, though it doesn't meet the criteria for GERD based on acid exposure time, will also show a similar gradient, again, because of the principles of inflammation and mucosal damage that this technology tests for. So just one last case about a case where mucosal impedance testing helps shed some light in equivocal testing. So this patient is a man in his 70s. He had a history of hypertension. He was sent for a GERD evaluation. He'd been suffering from recurrent pneumonia for 5 years, developed bronchiectasis and a chronic cough, but he did not have typical GERD symptoms and no improvement in his symptoms with PPIs. We did perform a GERD workup on him, and we found that pH impedance was equivocal in that the acid exposure time was 5.8. Demeester score was a little bit high, 15.9. And manometry showed normal motility. Biopsies in an otherwise normal endoscopy showed reflux pattern changes and some esophagitis, mild esophagitis. But despite these findings, our degree of suspicion for GERD was low. He didn't have typical symptoms. And as surgeons, we kind of go based on a paper published by Dr. Campos in the late 90s. That's something we use a lot. So basically look for a typical response to PPIs, typical symptoms, and then Demeester score. So he didn't have typical symptoms, and his pH impedance tests, though slightly abnormal, would not be enough to explain his symptoms, especially when you consider his normal motility and the fact that if he did have any reflux, we would expect his esophagus to clear it pretty quickly. So his symptoms, were they caused by GERD, would need to stem from refluxate, overcoming his esophageal motility, traveling all the way up into his pharynx and into his airway without causing heartburn or other typical symptoms, and again, overcoming his normal clearance mechanism. So we thought that would be unlikely. So we planned for mucosal impedance testing. This patient did not have signs of mucosal damage on impedance testing. And so we collaborated with his other doctors and with his pulmonologist, which led to him stopping his ACE inhibitor that he was on, which improved his cough. Concurrently, he was also found to have severe worsening chronic sinusitis. So he has endoscopic surgery planned for that. But again, given his very mildly positive pH impedance testing and strong esophageal motility indicating good clearance, we started off with a low suspicion for reflux as a cause of his issues. However, had we seen a GERD pattern on mucosal impedance testing and his symptoms persisted despite the above interventions, we may have broadened our suspicion a little bit, and at the very least, repeated pH testing, maybe with 48-hour with a Bravo. And at the very least, we also likely would have continued to monitor his mild reflux disease, with my view. So in patients who are being treated for EOE or reflux, our conclusion with this part of it is that mucosal impedance testing may also be helpful in monitoring the response to treatment. And that's something that my colleague, Dr. Hegde, will dive more into as she compares some of the literature going forward.
Thank you. Let's delve into the current literature now on mucosal impedance and its clinical applications. As you've seen with our prior examples, mucosal impedance measurements have a role in differentiating GERD versus non-GERD conditions. So this clinical trial by Vaezi's group out of Vanderbilt shows various esophageal conditions, namely achalasia, non-erosive esophagitis with and without abnormal pH, erosive esophagitis, and eosinophilic esophagitis, and as it relates to mucosal impedance measurements. What I want to draw your attention to here is how eosinophilic esophagitis is consistently presenting with low mucosal impedance all across the esophagus. As we've mentioned earlier, eosinophilic esophagitis is a histopathological diagnosis with more than 15 eosinophils per high power field. So the argument here made by this group, again, Dr. Vaezi's group out of Vanderbilt, is that with mucosal impedance, we can assess the entire esophagus as opposed to doing a few targeted biopsies, which can lend itself to sampling errors and false negative results. This study specifically also looked at 49 patients with dysphagia, and mucosal impedance was able to be predicted with pretty high fidelity, specificity and positive predictive value of 96%, as compared to histological diagnosis. This review article out of Australia highlights mucosal impedance as a diagnostic tool for GERD and other conditions. So let's revisit this GERD algorithm as Dr. Rafiki went through extensively earlier. The main take-home message I think all of us want to drive through in our presentation is that if there's conclusive evidence of GERD on endoscopic or pH testing, then mucosal impedance really doesn't add much value in the diagnostic algorithm. But if clinical criteria is not met in the case of equivocal findings, especially with acid exposure time being between 4 to 6% or less than 4%, or any of the other adjuncts, as we've discussed earlier, if they're equivocal, then there may be a role for mucosal impedance testing. And if there is mucosal impedance testing done and it's low, then it might provide support for anti-reflux treatment, whether medical or surgical. The other thing I want to highlight here, which we've talked about earlier, is low MNBI, which indicates mucosal damage because of decreased mucosal integrity, is an independent predictor of success of anti-reflux treatment. But MNBI is not always a useful study because it can't differentiate between stasis and mucosal damage and can vary with movement, swallowing, reflux, etc. And that's why it's primarily done during the sleep time. So with that hypothesis in mind, we would expect that with medical and surgical treatment for GERD, there should be an increase in mucosal impedance. So this study, again, by Dr. Vaezi's group out of Vanderbilt, shows how erosive esophagitis pre and post PPI can actually show a nice recovery in mucosal impedance at various locations along the esophagus. So one of the biggest implications, I feel, for this modality is its role in the assessment of its treatment response. So looking back at the case that we presented with GERD, this is how we would look. The mucosal impedance depicted would look like this. Pre-treatment and post, it may look something similar to this, or completely blue, or some version of this diagram. As we're nearing the end of our presentation, I want to, have some discussion about this. We've talked about the role of mucosal impedance in equivocal testing, but is there a role for it being a part of Barrett's surveillance? Some studies, pilot studies, preliminary data have shown that Barrett's has a very low mucosal impedance of almost 400 ohms, which is equivalent to severe esophagitis. And some studies have even shown some strong correlation with the length of low impedance with the length of Barrett segment. And these studies are not yet validated, but this is something that I think would be a great topic for discussion in the future. Additionally, we've had issues with insurance covering certain medications. So could this provide some objective measurement of treatment response? That way we can actually show insurance companies that this medication actually needs to be prescribed or covered for this patient lifelong, such as Dupixent or budesonide for eosinophilic esophagitis. Other things to consider is looking at post-myotomy for treated achalasia and its different reflux patterns. So, there's a lot of variety of reflux patterns in treated achalasias, ranging from stasis and fermentation to hypersensitivity to true acid reflux. So could this modality actually play a role in differentiating that? And then lastly, another thought was, could we potentially show esophageal involvement in systemic sclerosis, where we would have to otherwise take multiple biopsies all along the esophagus, await pathology, etc. So I want to wrap up this presentation with comparing the two modalities that we've discussed in this presentation, pH impedance versus mucosal impedance. So as we've discussed earlier, pH impedance really only shows a 1 to 2 day snapshot, 24 to 48 hours, versus mucosal impedance shows real time within seconds. The other difference is pH impedance has only 6 to 8 impedance sensors versus mucosal impedance has 40 impedance sensors. So you can see there itself is a major difference between the two, with pH impedance providing reduced sensitivity, specificity of only 64%, positive predictive value of 40%, versus mucosal impedance has much higher specificity and positive predictive value. Another key difference is with patients with pH impedance catheter, they're largely non-compliant because of its discomfort, versus mucosal impedance is done in the setting of endoscopy where they're already sedated. Now, some advocates of pH impedance over mucosal impedance would say that there is increased procedural time with mucosal impedance, but actually it's only 5 seconds per section, so it only adds maybe a couple of minutes to do this in real time. Whereas with pH impedance, it's very cumbersome to log the events, and we have to have reliability from the patients to actually log their symptoms and can be subject to error. The other key difference is mucosal impedance does not actually define the pH, versus we get more pH readings with alkaline and acid reflux with pH testing. So to summarize, pH impedance measures the changes in electrical impedance caused by presence of liquids or gas, as well as simultaneously measuring pH, versus mucosal impedance only measures the electrical conductivity in the actual lining of the esophageal mucosa. What it detects is pH impedance detects all types of reflux, acid, weakly acidic, and non-acid. With mucosal impedance, again, not showing a differentiation between alkaline and acid reflux. It only detects the changes in the integrity of the mucosa and whether something could indicate GERD versus eosinophilic esophagitis or other conditions. How it's performed, pH impedance is transnasal, mucosal impedance endoscopically, and currently pH impedance still remains the gold standard for GERD diagnosis, but mucosal impedance, as we've said multiple times before, is sensitive and specific for detecting GERD conditions and especially EOE, but most importantly can actually assess the chronicity of reflux damage. Disadvantages, again, pH impedance is uncomfortable, doesn't necessarily address direct mucosal damage, whereas mucosal impedance does. And it's relatively new technique and not widely available. So that's the biggest advantage, I feel. And lastly, its clinical applications is pH impedance is able to identify reflux triggers that we wouldn't be able to see with mucosal impedance, but mucosal impedance does give us an idea of maybe prediction of treatment response and could help us guide future management of these conditions. These are our references. Thank you so much for your time. Sorry we ran a little long, but this is a very exciting topic for us as well, as it's relatively new, and we look forward to the discussion that is to follow.
Thank you. It was a very nice presentation. I agree with Dr. Higbee that the real value of this technology is the assessment of treatment response. As surgeon, we are still trying to figure out what's the role of MI in surgical practice. Unfortunately, there's very limited data on surgical population. The very first will be presented in SSAT this year that looks at the surgical outcome and MI measurements. But we also need to look at these different testing as a complementary role. So pH monitoring quantifies the degree of insulting agents, measures the interluminal pH, whereas mucosal impedance measures the impact of this insulting agent on the mucosal integrity. So they are fundamentally different. As a result, they can be used as a complementary tool. So I always compare it to the role of these two and the way they interact with each other as A1C and blood sugar, fasting blood sugar. Fasting blood sugar is a snapshot, whereas A1C give us information about chronicity of the disease process. It tells us about burden of disease. As a result, MI can be a very good measure of assessment of our impact of surgical or medical treatments. There were a few questions in the by the audience. One was about different modalities. The very first version of MI was measurement by catheter. The next one was a balloon, and the most recent one is a cap. There is very limited data comparing these values, and the one modality that is available right now is the cap. So I assume all of the future data will be based on the cap. Some of them are based on the balloon data. And any other question that you guys want to answer from audience?
There's one about GLP-1s and PPIs. Like how do you tell patients to stop? Do they continue? What's the plan for that when it comes to impedance?
So for MI, I don't stop the PPI. Basically, because you are looking at the chronic impact of a disease. But for any pH monitoring, you would stop the PPI for 7 days. More recently, PCAPs have come to the practice. And the question is when to stop the PCAPs prior to pH monitoring. And majority of the centers still follow the same time interval as PPIs. But the recent data suggests that since they have a much shorter acting, we can probably stop them 2 to 3 days before the pH monitoring.
And Dr. Jayaraja is asking about Bravo and where does that fit into this?
Bravo is basically the gold standard to diagnose reflux disease. For the past 50 years, we've been using it to establish reflux as cause of the patient symptoms and use it as a tool to predict the outcome. That should be our first pH monitoring assessment tool.
And then Dr. Dunes, do you want to expand on some of the questions? You kind of answered some of them already, but about more technical aspects of the MyView.
Happy to. First of all, just to clarify, Shaheen is awesome and amazing, and thank you so much for your help with this. Just to clarify, the past 50 years, we've been using pH testing as our gold standard. We've only been using Bravo. The normals have been established for about 20. So I just wanted to clarify that. The technical aspects, there's been some questions. I have no disclosure for the company, for MyView, except for the fact that I was able to get the device, the system, for research purposes, but I'm not paid by them or anything like that. So my interest is genuine, but I don't have experience with all the other technologies that some of you were mentioning in the chat. Mostly just, it's hard to get these things. The technical aspect, it's really easy. It's really easy to use this device. And I don't think we have enough information for clinical surgical decisions. And Shaheen said at the very beginning of this, and I think so did Tala, that the way surgeons look at pH testing and impedance testing is different than GI. So GI they're looking at responses to meds and trying to figure out functional heartburn and whether or not there's something going on with hypersensitivity and whatnot. We're trying to decide if the patient is going to respond to surgery. It's a much higher bar. It's a much different thing. And I don't think that mucosal impedance is prime time for that decision making right now. But if enough of us get our hands on it, enough surgeons get our hands on the device and can collect some data, I think it can be very useful in the future. So those are my comments. Great job, guys.
Perfect. And have you ever used it alongside EndoFlip? I was just wondering because I'm trying to package everything for my patients now too. So if you are the one that scopes them, you do the EndoFlip instead of like conventional manometry. I think there might be a really good role for that too.
That's totally awesome. However, my flip is in a different location from my view. So I couldn't get to. So right now, no.
Not
Great
yet,
point,
at
though.
least.
Yeah, exactly.
Show
Flip,
them this talk.
Flip gives you some upfront basic manometric information. Is more measurement of distensibility rather than measurement of the contractility at the index endoscopy. By no means we are at the position to not doing manometry based on just endoflip measurements, but it has some value. Again, it's something that can
Well,
be used intraoperatively because it gives us information about the adequacy of myotomy during our endoscopic or surgical myotomy. But it's still, all of these physiologic testing are complementary to each other. Each of them gives us some aspect of function of esophagus that the others cannot. And if all of you are interested to learn more about this physiology testing, there's a very, really good session at SSAT. It's Tom DeMister lecture series that the speakers will talk about different modalities and role of each in predicting surgical outcome.
Awesome. Excellent. So if you didn't hear it already, please come to DDW because there's definitely a lot more to talk about. But thank you so much, Dr. Azzi, for being our moderator today.
Thank
Excellent
you.
job to our fellows as well. And stay tuned. Our next talk will be coming up, and it is about robotic tips and tricks for Ivor Lewis esophagectomy, and that will be on March 24th. And without further ado, if everyone, could you unshare your screen? And if everyone would please turn on their cameras for a second. We can take our Twitter picture. Okay, ready?